Thanks, Val. Hello and welcome to our third session in this special on-call series, A Collaborative Approach to a Chronic Care Problem, Evaluative Results from the Atlantic Healthcare Collaboration, or AHC. Today's call will mark the final session of this series where we will continue exploring results and lessons from CFHI's AHC, a pan-regional quality improvement collaborative for improving care for patients with chronic disease across the Atlantic provinces to inform strategies for designing, implementing, and evaluating quality improvement collaboratives. I'm Megan Roster, and I'm pleased to be your host today. We're joined by more than 150 organizations from across the country who have registered for this series. To join us live today, also access on-demand sessions and resources for this series. We're pleased to be providing simultaneous interpretation on today's call for a Francophone audience. As I introduce our speakers, please take a moment, if you haven't yet, to introduce yourselves in the chat box, who you are and where you're from. We're pleased to welcome today's speakers to the call. Here in our virtual studio today, we have Claudia Marr, who's Senior Improvement Lead here at CFHI. She brings more than 9 years' experience in both nursing and quality improvement. Claudia plays a leading role in a number of CFHI's initiatives, including the AHC, the Inspired Approaches to COPD Collaborative, the newly launched Acute Care for Elders, or ACE Collaborative, as well as the development of CFHI's Organizational Assessment Tool and CFHI's First Change Package. And joining us virtually today is Jean-Louis Denis, who is a member of the Royal Society of Canada, Fellow of the Canadian Academy of Health Sciences, and Chair of the Advisory Board of CIHR's Institute of Health Services and Policy Research. He was the founding academic coordinator of the Force or Extra initiative from 2003 to 2007 here at CFHI, and is the lead academic faculty for the Atlantic Healthcare Collaboration. Since January 2014, Jean-Louis is an International Visiting Fellow at the King's Fund in London, UK, for an initial period of 2 years. I'm also joined today by CFHI's Senior Director, Jen Verma, who was instrumental in the development of the AHC, as well as our on-call producers here in the room, Kelly and Sheena. So we're happy to welcome folks back today who took part in the first 2 of 3 webinars on October 21st and November 25th of this series, where we looked at self-management strategies for healthcare improvement and learned about strategies for engaging in regional collaborative quality improvement efforts from 4 of the AHC teams. This included Health PEI's Supporting Realistic Behavior Change team, Western Health, Horizon Health Network, and Nova Scotia Health Authority. For those who are new to the series and joining us today, let's kick off with a brief overview of the objectives we've laid out over the course of this series. We've set out to demonstrate solutions for making the shift from disease-oriented care to patient and family-centered care that meet people where they are, to profile the experience of teams scaling their improvement projects and spreading them across delivery systems, and also to assess strategies for motivating the clinical frontline to make disruptive change to improve chronic care for patients and families. In today's session, Claudia and Jean-Louis are going to lead us through the core components of the Atlantic Healthcare Collaboration as a regional quality improvement collaborative, looking at the scope and the aims. We'll also look at the evaluation strategy used to measure the impact of this improvement work at both a collaborative level and a team level, and discuss some of the outcomes from this work. With that, let's start by looking at some of the backstory. In Atlantic Canada, we know people live with greater risk factors for and higher rates of chronic disease than the average Canadian. And the health system costs have historically risen faster than other parts of Canada. Given the burden of chronic disease in Atlantic Canada, there has been a need to find an innovative approach to supporting patients and managing these conditions. In 2012, CFHI began addressing this need through the signing of a charter with all Atlantic regional health authorities to carry forward improvement initiatives that focused on patients and families, was driven by a diverse network of teams and senior leadership to create sustainable changes in the way care is designed and delivered in the region. By establishing multidisciplinary teams to address gaps in care delivery for chronic disease, patients and families, we committed to make best practice the most common practice. Overall, there are 11 improvement teams, 5 in Newfoundland and Labrador, 2 in New Brunswick, 2 in PEI, and 1 in Nova Scotia. The One Improvement Project in Nova Scotia was agreed upon through participation of all district health authorities in the province. I'd encourage you to visit our webpage to learn more about the 11 improvements, the teams, the CFHI faculty, mentors, coaches, and staff who were all involved in this innovative pan-regional quality improvement collaborative. So what you see here on the screen is a summary of the most common quality improvement collaborative, or QIC, components that were captured in a Millbank Quarterly Systematic Review in 2013. The AHC is a quality improvement collaborative, and this presents a nice summary of the core components, focusing on improving provider practices or patient outcomes, structured activities for developmental team and cross-team learning, combining expert evidence and QI with an improvement model that prioritizes measurement and feedback, and it also relies on multidisciplinary teams who are executing small tests of change. Using the chat box, please tell us, why did you join today's webinar? We're also curious to know if you've ever been involved in or are currently involved in a QIC. If so, tell us a little bit more about it. What does it entail? How is it being evaluated? Please use the chat box to share your experience. Working with the 11 AHC improvement teams, CFHI supported this QIC through 2 levels. One being the overall collaborative level, which consisted of an executive committee formed of the RHA CEOs and VPs who met quarterly throughout the collaboration over strategies for sustaining and spreading this work. Their involvement was key to ensuring the cross-regional approach was supported, and also that their own teams had support on the ground and from the executive level. Secondly, CFHI supported the teams through a number of mechanisms, including many curriculum components, for example, access to CFHI webinars, 4 in-person workshops, pairing with an academic mentor and improvement coach, as well as measurement support and in their plans for spreading their success. Ultimately, looking across these 2 levels, CFHI has examined what teams achieved in terms of quality improvement and chronic disease management and on the collaborative level, what we learned in terms of how we supported the teams, the network that developed cross-regionally out of this approach, and ultimately, what we learned about sustaining improvement beyond financial support once the collaborative ends. We'll now turn it over to Claudia, who will lead us through some of the evaluation approach and methodology.
Great. Thank you, Megan, for that intro, and hi, everyone. So I'll expand on what Megan just ended with by mentioning that at the outset of the AHC, we established 3 core evaluation objectives. So we set out to design a program with evaluation and measurement integrated throughout it that would help us understand if we met the collaborative's overarching goals. So we wanted to first learn about some of the improvements in chronic disease management specific to each of the improvement initiatives. And I just want to give a shout out to Janet Fisher, who is a team lead on our Eastern Health team. And also, I'm not seeing any activity in the chat box, so we would love to know, and even as I'm speaking, have you participated in a collaborative? Do you know what collaboratives are? And how have those been evaluated in your context? And we'll get back to your comments later in the call, hopefully, if we get a chance to. So first, we wanted to learn about the improvements in chronic disease management, as I was saying, and that includes the local, regional, and provincial lessons learned and results related to chronic care best practice, as well as the implementation as it relates to specific diseases in chronic care intervention. We also wanted to understand the barriers and the mitigation strategies related to implementation and some of the implications for sustainability at the local context and more broadly, as well as any policy implications as well. Second, we wanted to learn about the quality improvement processes, and that was using our CFHI improvement model and approach. We wanted to gain a better understanding of and pull lessons on how teams approached the assessment, the design, the implementation, and evaluation of their initiatives, and that readiness and capacity required to do so. Third, we wanted to learn about the essential elements of healthcare quality improvement collaboratives by testing the usefulness of the AHC collaborative components. And some of those components Megan touched on, but that included the in-person and remote learning modalities and an adult learning model. There was, of course, our extensive network of mentors and coaches. We also tried to combine evidence-based practice in chronic care as well as curriculum on developing the improvement in capability and competencies of our teams. There was an interprofessional and cross-regional networked approach. We also aim to connect delivery to the policy sphere by engaging policymakers in our face-to-face workshops and also keeping them in the loop about ongoing progress through regular teleconferences. And of course, we wanted to understand the overall role of CFHI in developing and delivering a quality improvement collaborative. So I'll move on now in terms of our data sources. So our evaluation plan, which we're actually writing about in an upcoming Longwoods Healthcare paper series that will be published in January, and which really became a template for future evaluative work across the foundation, used what we consider a mixed method and integrative approach. So for that, we conducted document review, and those documents included things like progress reports that teams were asked to complete on a regular basis throughout the collaborative. It included their measurement plans that set out the key measures they were tracking to determine if the changes they were making were actually leading to the intended results. We also looked at their final reports that they submitted back in September of 2014, in which they documented their progress made to date, some of the process and outcome results that they've achieved at that time, as well as the key learnings and lessons learned from not only having implemented or designed an intervention, but the lessons from having participated in a quality improvement collaborative. We also used surveys as a data source, and those were surveys that we would have conducted after each of the major collaborative activities. So for example, we had a series of surveys against the workshop and the webinar learning objectives. We also distributed a survey within our coaching network to understand the value and the needs of the participants that were playing that role. And those really have supported us in continuous quality improvement, or CQI, by helping to inform the design and delivery of upcoming webinar or learning activities, as well as the learner level knowledge and skill development against the key learning objectives. So to see if our teams were actually gaining that knowledge and capacity through the curriculum and activities that we were delivering over the course of the collaborative. And we also used social network analysis, or SNA, and I'd be curious to know if any of you are familiar with that or have used it within your own initiatives. And we use that as one method to help us measure and visualize the growth of the network, and also to determine if this network can be sustained at the end of the collaborative. So SNA is both a theory and a method used to understand how units, whether they be individuals, organizations, are connected to one another in complex patterns of relationships. So as part of our summit of evaluation, we also conducted semi-structured key informant interviews, as well as focus groups with over 20 participants, which were largely team leads and team members, as well as coaches and mentors, the CEOs from our collaborative's executive committee. And that was to unpack some of the learnings, the outcomes around their improvement initiatives and learning experience. So it really helped to address gaps that we wouldn't have, in terms of information that we wouldn't have had or found in the previous documents we would have analyzed. So what did we learn about the team's ability to assess, design, implement, and evaluate their initiatives? So the 11 teams over the course of the collaborative progressed to very different stages along a quality improvement team maturity scale. And what you see on this slide reflects the time one, so when we would have initially conducted the evaluation of the collaborative back in last fall and winter. And what we see in front of on this slide, and it is quite small, so I apologize, but essentially the 11 teams were able to assess their underlying problems. So understand the complexity of the initiative or the issue that they were trying to address, articulate a problem statement, understand their population needs in order to be able to then go ahead and design the initiative. And so 7 of our teams were able to actually get to the design phase and to design innovative solutions that would meet the needs of their populations. And just note that 2 of the Labrador-Grenfell Health teams actually opted to exit the collaborative for various reasons, and another one later joined the collaborative. And we also had 4 teams at that time that reached the implementation and evaluation phases of the improvement model. Since then, our time 2 actually highlights the fact that 2 additional teams have been able to achieve implementation and evaluation. And we, of course, consider that to be a normal part of the improvement journey, as we know that real change takes dedicated time and commitment, and that was certainly a finding from our evaluation. And we know that many of the teams that we haven't mentioned in the previous 2 webinars are continuing their improvement efforts until this day, which we're quite pleased about. So the 11 team improvements supported patients in families with various issues, and that included diabetes, chronic obstructive pulmonary disease or COPD, mental health, as well as multi-morbidity issues. And some were based in acute care settings while others took place in the community. So in the 2 previous webinars, as Meg mentioned, we described the chronic care improvements achieved by 4 of the teams who reached implementation and evaluation of their initiatives over the course of the collaborative. So I'm actually not going to go into too much detail about those teams here. I would encourage you, however, for those who are interested in learning more about those teams, to access our on-demand webinar recordings that are available through our website. And we're also going to be developing, and we're going to be making impact stories of those 4 initiatives available on our website in the early new year, I believe, and Meg can correct me on that. So for the purposes of today's call, I'm going to share one other example of an AHC team who has been able to achieve implementation and evaluation, and they addressed COPD as part of their initiative, and that's Central Health based in Newfoundland and Labrador. And you can see a small square with some information on them to the right of the slide, and I'll expand on that. So in their context, COPD is the leading cause of hospital admissions and emergency visits, and they have the longest length of stay of all chronic conditions. And that's not unlike any other areas in Canada and elsewhere, but it is a particularly big problem in their context. So they started addressing this by giving patients and families better self-management tools so as to optimize their health, as well as to reduce the strain that COPD puts on their healthcare system. So as part of their initiative, Central Health set short-term goals of standardizing and enhancing the quality of COPD care, as well as improving patients' self-confidence in their ability to manage their conditions. So the team created a 3-pronged pathway to address the needs of patients and their families and improve the processes of care based on the Inspired COPD Outreach Program. That's a hospital outreach initiative developed at the Queen Elizabeth II Health Sciences Centre in Halifax, Nova Scotia, which some of you may be familiar with. And these approaches that Central Health adopted included a standardized patient order set, the redesign of an existing asthma care center into an ambulatory respiratory care center, and the development of an outreach program for patients with advanced COPD. So when they created those standing orders and care maps, those largely entailed having standardized medication prescriptions and a pathway for the clinical front line. And in order to smoothly implement that, they also provided education to providers on the programs and services that they were developing that actually existed, but also to enhance the uptake of those standing orders, as well as the referral and coordination of services within the team. They redesigned the asthma clinic at the James Patton Memorial Regional Health Center in Gander, and so that was an existing clinic that was being underutilized, if you will, and they converted that into an adult ambulatory respiratory care center, which uses a 9-month pathway combining both on-site medical management along with education and self-management support for people with mild to moderate COPD. So those are patients that can actually are mobile enough to get to the clinic. And they report seeing more than 150 patients since opening in September 2014. And they're now measuring the implementation, access, effectiveness, and sustainability of the center. Since the Atlantic Healthcare Collaboration, they've also participated in CFHI's Inspired Approaches to COPD, Improving Care and Creating Value Collaborative, which is a 12-month collaborative that began in September 2014. And through that, they were able to continue on with their improvement efforts. And since the first enrollment into the outreach program back in January 2015, more than 21 patients have now been enrolled, which is tremendous progress. So I'm actually going to skip over this next slide, as I mentioned, because the resources are available through our recordings of webinars and on our website. And I'll go straight to the next slide, Megan, if you will, to talk about our social network analysis, which I introduced. So one of our objectives was to build a diverse network of chronic care leaders across Atlantic Canada. And many studies have shown that people who span boundaries in their work are in an advantaged position for the adoption of new and potentially useful ideas. So in this case, building networks in which individuals from different provinces become connected provides us with the opportunity for programs to learn from one another and to potentially exchange information in a collaborative way so that the care provided to patients is improved. So these studies suggest that the structure of the network affects performance. To undertake the SNA, surveys were administered to program participants at 3 waves over the course of the collaborative. So at the second, third, and fourth and final face-to-face workshop that we hosted. And those were approximately 6 months apart, if you will. So 3 networks were measured, the know, the sharing, and collaboration. So the know means I personally know Megan Rossiter. The share means I share information on chronic disease management or quality improvement with Megan. And collaboration means that we're actually collaborating on an initiative related to our context together. And to do that, we brought on Tom Valente, who's a guru on networks and public health out of UCLA, and he's been a tremendous advisor to us along the way. So this visual reflects results from a survey we conducted at time 1 of all participants, including CEOs, and that was based on the questions about who each person knows, shares, and collaborates information with, or collaborates with. So based on the follow-up survey at time 2, and that's the image you see on this slide, we saw that the AHC Collaborative provided opportunities for participants to develop networks not only locally, but cross-regionally and provincially. So from the baseline to follow-up survey, increases are visible across all types of connections in terms of know, share, and collaborate. And the network density, so that's how connected people became, at least doubled across all types of connections. And I'll just get Megan to go back to the pre for a second, just so you can see the difference in density. So, and then go back. So much more dense in terms of the number of ties that we're seeing there. So for example, at baseline, 33% of the possible ties among Prince Edward Island, or PI, participants already existed, and those actually increased to 100% at the follow-up. Newfoundland participants reported having no ties to PI participants at the baseline, and that increased to about 13% at follow-up, and those are just a few examples. So the No network showed the greatest increase, with 132 new connections developed from baseline to follow-up. However, proportionally, the Share network grew the most, with almost 3 times more connections over that same time period. So a lot of people were sharing information about chronic disease management and quality improvement, which is not unusual. Importantly, this is a great lesson for the foundation. So while we at CFHI fostered the strongest connections at the outset, we saw that over time, teams became much more closely connected to one another, as well as to the local expertise of faculty, coaches, and mentors. So we're currently in the process of administering a final survey, and I peeked at the results today, and they do seem promising, and it does indicate that the network is continuing to grow, which is great. And we're also going to be writing about the methods and results in a peer-reviewed journal article, I believe in the early new year. So on that note, I'm going to turn it over to Jean-Louis, who is going to share some further evaluation results at both the programmatic and the collaborative levels. So over to you, Jean-Louis.
Okay, thank you. So as Claudia mentioned, I will talk more about what we learned from running a collaborative like this. And maybe just as an introduction, like when we talk about collaborative quality improvement, we look at a very specific strategy to transform and improve a care system. Like it's very different than implementing big reform. It works on the assumption that there are latent capacity in the system that we can tap on to bring about improvement, and that there are opportunities to develop new capacity if we put teamwork process in place. So that as a general introduction. And I will first talk about what we learn about what what are the components that appear to be more useful in this experiment, and what skills were gained along the way. So if I guess what we learn, and I won't detail on this, is that developing capacity for improvement is closely related to the kind of support you receive. So one of the key thing in collaborative quality improvements is, do teams receive some support? It may be in their environment, it may be from resources outside their environment, but that can guide them in their improvement journey. And we use a kind of dual coaching model in the Atlantic collaboration, which means that each team receives specific support in terms of change and improvement, and specific support relate to their area of intervention or expertise. And we also run a set of workshops based on, I guess most of them based on need assessment, because team may work around different disease or different health problem, but they face common challenge along the way. So we run workshop where we mix expertise from research, evidence, and from leaders in the field to help them, I guess, refining their strategy of improvement. And one of the payoff of these workshops, and it is reflected in the social network analysis, is that team have occasion to connect together, and that's very important, the kind of peer learning, because they share in different contexts similar challenge in their improvement journey, and that appears very important. Maybe less important is the platform, the desktop that was developed. We don't mean by this that it was not useful, but I guess people use it as resources, but they learn probably more with direct contact or discussion with their peer and the resources that are provided. People develop competency or bring competencies along the way, and driving a collaborative require to mobilize people, and for this you need to be able also to communicate your ambition. So the notion of communication, community engagement, and some technical aspect like a collaborative quality improvement is also project management, how you evaluate your intervention, and also the question of implementation and spread. And the meaning of this will vary across contexts, but again, you find common element, the question of leadership, what it means to take clinical leadership for improvement, to secure commitment from senior leadership of your organization, and to secure it on a day-to-day basis, not just at the onset of the project, and learning how to be an effective team. And this is essentially quotation that reflect what people get from the experiments, and I guess what I take from these quotations is collaborative quality improvement, and it is implicit in the notion of collaborative, is about bridging. You bridge different expertise, you bridge different group of professionals, you bridge people that are part of different organizations toward a common goal. So, and Claudia referred to this, and if we take it at a more aggregate aspect, what we learn about these four classical phases of a cycle of improvement, and what are the key factors in quotation in achieving each of the steps, And in terms of assessment, it's really relate to stakeholder engagement. And we know this clearly in change management, that you need to get on board your key actors, key collaborators early in the process, and also securing their position within the collaborative quality improvement. Like, as you know well, working in healthcare, it's a highly pressure field on a day-to-day basis, and suddenly you get involved in a new experiment like the collaborative, and you have to make time for this. And also you have to understand well where you will go with this. And and this is part of the motivation. So the type of problem you will address, the goal of the intervention, need to be fleshed out early in the process to try to secure the commitment of the various stakeholders. You have to go beyond goal definition and a problem you want to address. You have to design an effective intervention, and there are two key components in this, which is how you work as a team in designing this intervention, and also how you bring in evidence. And evidence are of two sorts, like you have the scientific evidence of what works, and then you have the knowledge and experiential knowledge about context, which help ensuring the question, what will work in my context to address this specific problem? And this vary across the team. And then a good idea, a good intervention, ability to collaborate are not sufficient. The test is in implementation. And we sort of found similar list of factors than the skills we described earlier. Like you need teams needs first to secure an organizational commitment and engagement, and something that we know well from high-performing healthcare organization is that the support of senior leadership team is very important. It sends strong signals about the importance of the collaborative quality improvement. It's also helped connecting the collaborative with the key strategic orientation of the organization. So one of the message here, if it's too peripheral, if it stays in parallel, a team will have more difficulty in finding support and resources along the way when they face challenge or needs to expand their development. So something, again, that we know well in healthcare and in quality improvement, staff turnover can be a problem for two things. Collaborative improvement is driven by people who work collaboratively, so if you change people, learning to work together needs to be done again. And probably more importantly, improvements takes time. So if people are too mobile along the way, they will not have time to learn how to bring about improvement in their own context. And again, as you know, in healthcare, competing priorities, it's the reality of all of us in work, is our people, and it's not only in terms of resources like financial support and so on, but it's also, do they will have time to pay sufficient attention to the collaborative improvement? And then that's crucial, because we know, like, people can come at nice workshop, work well together, but if they are too pressured to focus on other things, it will dilute through time their implication and their project. A good strategy is probably to to bring around the table on a quite sustained basis patients and people from the community, and they will help a team to stay focused on the collaborative. So they may attenuate this problem of competing priority, plus they bring, of course, key insight around their ed need and implementation and so on. And I won't go far on evaluation. Claudia discussed this at length, but it's this idea that developing a culture of measurement and of using data for improvement that fit well the context of these teams. So it may not be the biggest evaluation of the world that they will do, but the important thing is that they run an evaluation, they get data in collaboration with external resources that will help them making sense of their experience and achieving improvement. So I guess I cover most of these factors at the right, like collaborative means you need a team that work well together, and some organizations have more assets in this regard than others. One of the challenges is the kind of resources they may need along the way, and as you know, more we can work with the existing resources, more it's easy for healthcare organization these days. Having the support of a foundation like CFHI help a lot bringing some external resources at key moments of the improvement journey. So that, I guess I will stop there for this one. And what did we learn about running this collaboration? So the importance of having a clear executive mandate, and I think one of the great momentum of this initiative is the charter, like Megan referred to, and having provinces that get committed to make to get the best out of these projects, and this theme is very important, and then cascading down this mandate in the system. We mentioned it, having the support of senior leadership is very important. And developing capacity, like all these aspects on curriculum, expertise, resources that were provided within the context of the collaboration with CFHI is very important, because most of the time organizations have a lot of capacity, but they may not have some of these key resources that they will need along the way. And for example, we had a Wagner on the advanced chronic disease management, and I found it was very useful because each team were able to connect with him, share experience, and it's always useful to bring someone new in the conversation that is outside our day-to-day interaction and experience. And main limiting factor, and this connects a lot with the question of sustainability, is you generate an important momentum through this experiment. Everyone is, or most of the people are very enthusiastic, including the one that is speaking now, and CFHI, and what's happened after. So, and one of the antidote of diluting too much of these efforts after and sustaining it, in my view, is working and maintaining active this network of relation among teams. And also, I guess their responsibility to policymakers or people at a more policy level to look globally in their province and what they have to do to to sustain this momentum for improvement regarding chronic disease in their province and in the Atlantic. So we mentioned a lot about competing priority. What did we learn about spread and sustainability? So, and on my side, that's the main message. Changing the way we work in healthcare and taking seriously the question of context of continuous improvement takes time, and policymakers, senior leadership have to be patient. Like, it's not easy to achieve this kind of project, and these teams address very important health problem, and you don't create in a couple of months major shift in a society regarding chronic disease. So it's really installing progressively new capacity for improvement, but it takes time. So that, and people need to be patient. Team readiness are important to their capacity, their ability to work together. And more we discuss early in the process the question of how a given team will sustain their effort beyond the support of an external agency like CFHR or a partner like CFHR. For me, it's crucial. And of course, securing at a maximum resources, and I mean commitment of people to a local coalition that stay attached to the initiative beyond the formal period of the project. So, and as we face in any initiative to bring about change and improvement in healthcare, there is a trade-off here. You may have a project that is really focused, like maybe developing more self-management skill among a group of people facing diabetes. This is very important, and we know that evidence support this a lot. But you may need something else to shift the way that a system focus on key priority like chronic disease management. But at the same time, if the target of a given team is too ambitious, they will have difficulty achieving something satisfactory. So that's always a delicate balance, and again, coaching may help focusing this. So, I guess my time is finished, Claude, Megan, is it right?
Please continue, Jean-Louis.
Okay, so, sorry. Okay, so, and we start to map the different projects along these three dimensions, and one is pervasiveness, and I like to see these dimensions as questions we may ask along the way, and also when we think about launching a collaborative. Do we want to focus on a very, very local experiment, or we want also to develop more broader, like it may be a new program to manage a specific chronic disease in a given province, and to support this, we may want to play on various levers, including the way we allocate resources to make it a priority. So that's one dimension. Another dimension is the depth of the change that is involved in a given project, like more in collaborative improvement. Some team may rely a lot on self-management and I guess it's the right word, empowerment of people facing a given health problem, and I think in mental health, for example. And this may represent a major shift in the way we usually address these problems. So one of the messages here is behind collaborative quality improvement, you may carry on a very ambitious project of change regarding the way, in quotation, we do business. And these change may be in the mindset of the people too. The way they will see their role as professional, the way they will see the role of patient, as an example. And then one of the dimensions is size. Like we start early on by mentioning that the 4 Atlantic provinces signed on a charter and a call for proposal for a project across the 4 provinces. So a next step can be to say what would be an agenda to push this forward from this experimentation and to cover broader site in each province, for example, or maybe a larger set of province, and I'm putting this at the extreme. But I think the combination of pervasiveness, depth, and size are useful to understand the kind of journey that the team navigate along these experiences. And then just to finish, like if we map the different projects, and I won't go in detail around these dimensions, we have here like some project that focus, and this is not negative, like I underline this, some project that focus more on program locally, some project that look at impact also at the way department operate, and some project that have in their ambition a larger system scope. And you need probably to build on all these levels along the way. So one of my, I guess, of the learning of these kind of initiatives is that an improvement journey is always embedded in a regional and in a system level context. And at some point, a system or regional authority, or depending the system, need to look at team and need to look at what they will need to achieve more locally. So, and maybe some additional consideration. What this Atlantic collaboration show us is that there are really good opportunity in Canadian context, a context that that many people say it's very difficult to bring about change and improvement, and I think this kind of approach may make us more optimistic. It's possible to drive improvement in the context and overall with a relatively low level of resources but high level of commitment. The role of patient in co-design is critical. It's helped to keep focus, it's helped to innovate, and it's helped also to sort of move a bit the center of gravity of the healthcare system, because we probably focus too much on us as professional and our manager and so on. And policy implication, I think more we will take the route of collaborative quality improvement, more we will need a sustained dialogue between people who work at frontline, manager who manage the delivery organization, and people who do policy and think about helping people in the system to improve. And capacity development is important, and it's probably something that we neglect too much in this big sector, the healthcare sector. And there is an appetite for capacity development, for improvement. So thank you.
Thank you, Jean-Louis. So we now have an opportunity to take your questions. So please use the chat box to the right of your screen to ask your questions, or if you have additional reflections from this session. So in the meantime, since I don't see any activity in the chat box, I'd just like to share, we'll start with a reflection, I guess. So Dr. Ed Wagner, who's credited with the development of the chronic care model, which was used as the basis of the approach for the AHC, he highlighted two key opportunities that the AHC touched on, one being the patient and family considerations, and two, the self-management learnings. So given that I'd like to take advantage that we have Jen Verma in the room, our Senior Director, I wonder if you might want to expand on this a little bit.
Sure, and thanks, Jalomine, Claudia, and Megan for providing such a really nice overview of our lessons learned on the collaborative. We will have upcoming a healthcare papers issue that you'll hear from Edward Wagner himself on this, but he drew our attention to two areas where he felt we really made some good decisions from the outset. And those decisions were really informed by the teams that we worked with and the executive committee that came together to strike this collaboration, I have to say. But focusing on patient and family engagement, and also the self-management component. And if you listen to that call where Western Health had talked about the role that self-management played in their intervention, and you heard about some of the pre-testing and post-testing of providers in terms of their abilities and knowledge and skills in delivering self-management education, then you'll remember that she had talked about, typically when you ask providers to what extent they feel confident in being able to deliver their self-management education, they'll oftentimes score themselves quite well. And I think it's intrinsically something that providers feel that they can do quite well. Interestingly, what you see time and time again is that with some reinforced training, it raises awareness to areas that need tweaking. And so in that case in Western Health, when they, after the training, re-asked the providers about their skill level and ability, they ranked themselves more poorly at that first outset. So, Ed Wagner's point was, when you look at that chronic care model and all of its components, we tend to underestimate the extent and work and continued work, that professional development that's continuous, that's needed around self-management, especially as we learn more about chronic disease and to the Nova Scotia Health Authority team that talked about, when people are living with 2-3 chronic conditions. Well, that's new terrain. So it's really testing the limits and our understanding of how to provide self-management education. The other thing you'll read in the healthcare papers issue, and I really appreciated this, so we had the current executive committee chair, Richard Wedge, Dr. Richard Wedge, as well as the Minister of Health from PEI, Department of Health and Wellness, Minister Doug Curry, talk, and they actually said, constructively, this collaborative really needed to involve more deliberately patients and families at the outset as partners. And John, we talked a little bit about this. So Ed Wagner said, you got that part right, but what we then heard was, but we needed to make that not optional, but much more formal and a part of how we design the collaborative from the outset. And we've taken heed of that advice in our following collaboratives. And then the last thing I'll just say that both Ed Wagner as well as Pedro Delgado, who's a lead of quality improvement collaboratives at the Institute for Healthcare Improvement, he's contributing to this issue as well. They both felt, I thought this was an interesting outsider perspective, that there's so much opportunity in the Canadian context for pan-regional, pan-Atlantic, pan-provincial collaboration that they unfortunately didn't see in their own country context. So just reflecting on that, I just said to myself, we have so much opportunity, and sometimes it takes an outsider perspective to be able to see that.
Wonderful. Thanks, Jen. Folks can see, once I click here on the screen in front of them, some of our key reflections from various stakeholders. So with that, I'd like to take a moment to ask our speakers, what's your single biggest reflection on a personal level from the AHC approach, aka your biggest takeaway? And just from my perspective, given that I was the regional liaison for this collaborative, it actually came out in our evaluation that the secretariat support that CFHI played between the CEO level and the team level was key to making improvements happen, as well as the role that we dedicated to having this regional dedicated CFHI person to liaise with the various levels of the collaborative. So it was noted that this flexibility and nimbleness was greatly appreciated from the team level, CEO level, across all of our stakeholders. So Jean-Louis, I wonder if you want to share your biggest single reflection from the AHC approach.
Well, I guess one is refer to my note on optimism. I think it's possible with a structured approach to generate this kind of initiative and to see a lot of commitment of people in doing this. Like people work hard in the healthcare system and you arrive with a new initiative that they can co-design, that they can develop and make sense for them. And from there you generate new capacity for improvement. So I see this kind of experience here and in other countries. More, I think we too much unexploit this. And I think it reveals also the importance of the policy level, how we can, as Minister of Health, as department, help these kind of things happening more in the system. And that for me is a kind of key learning and insight from these dynamics.
Wonderful. Thank you, Jean-Louis. And Claudia, yourself, what's your biggest reflection from the AHC approach?
Well, thank you, Megan. I actually have two key reflections, I think, and they both intersect, of course. But one is about the scope of the intervention, and the other is about measurement. So first, I think on scope, having a focus on collaboration with a well-defined scope is really essential to ensure the effectiveness of our programming at CFHI. And although we initially conducted an environmental scan and held meetings with senior Atlantic leaders to identify chronic disease as the agreed-upon cross-regional priority and improvement project focus, the final AHC evaluation actually revealed that some of the team members perceived that broad chronic disease prevention and management focus as pretty limiting in terms of targeted curriculum, support activities, and transferable learning. And I think we felt that from a CFHI perspective when it came time to designing and delivering the curriculum to a number of teams that weren't necessarily advancing at the same rate or in the same ways. So I think when designing future collaboratives, one of the things that we started to do is to spread best practice focused on a specific issue, like the COPD collaborative that I mentioned earlier, or another spread collaborative that we launched on reducing the inappropriate use of antipsychotic medication in long-term care facilities. And so just as we're focusing and narrowing the focus of our collaboratives, we've also learned to narrow the focus of our measurement approach. And we do that because another lesson from the evaluation was that across organizations, we noticed that the resources and capacities for evaluation and measurement greatly varied. So recognizing those capacities at the outset of the initiatives, as well as ensuring that resources are available for the spectrum of evaluation and measurement training needs of participating teams are really important collaborative design considerations that have helped us to ensure that teams are adequately skilled at the outset to carry out those performance measurement and evaluation functions within the improvement. Thanks.
Great. So folks, we're actually coming to time, and I'd like to remind you that today's session will be made available on demand, along with the previous two webinars as part of this series. You can see our full list of offerings at our on-call website at the link provided, and we will be sharing with you via email access to these recordings and available resources, including the AHC communications briefing and the evaluations findings briefing. Jen had already touched on this. We'll be sharing some key deliverables in the new year, including the impact stories for the AHC teams, as well as a special issue publication through Longwood's Healthcare Papers. We'll be making that available to you via our website. So before folks log off the line, if you could please take a moment to fill out our quick polling survey that you see on your screen, that would be greatly appreciated. I'd like to say thanks to our speakers today for joining us, and to all of you for attending this session and your participation in today's discussion. This concludes today's webinar.